The house. It is the one and only Tim Moore, President, CEO, Mississippi Hospital Association. Morning, sir. How are you?
Good morning, Paul. I'm great. And yourself?
You've been traveling a lot, haven't you?
Been on the road a little bit, trying to find solutions for our hospital.
Did you find any?
Well, not yet, but we are working on a few.
Did you look in the right places?
Well, that maybe that's what I need is more direction on where to go. It's a challenge these days.
Looking for love in all the wrong places, as Johnny Lee hit. Maybe it's looking for solutions in all the wrong places. Then, well, look, this is serious. I did hear one legislator who said it made some sense to me. He said there was a combination of reasons for these hospitals to be closed, and I don't want to beat a dead horse on here or too much, but it seems like we negate sometimes the administration part of it. And I know you know that also is part of the reason for these failures.
Yeah, I don't as much probably as some of our legislators may do, because I look at things from an industrial perspective. If you look at the hospital industry and you even break the boundaries of the state of Mississippi, you see the similar issues. So, I have to say that as an industry, hospital administrators and CEOs didn't forget how to start running hospitals just in the last couple of years. So that's not the case. Now, is there a situation where there's stronger management in various facilities across the state, across the country? Well, sure there are, and that's for a lot of different reasons.
Yeah.
But I can't say that all in all that where we are today is a management issue. And I don't know how anybody could possibly say that.
I got to believe there are rules and regulations that the government puts on them. So most of those, if they are abiding by those rules and regulations, are there's enough checks and balances in there.
Absolutely, they are. And of course, those checks and balances create cost wherever you go. I was in at a meeting not long ago, and actually was in Arlington, and was with 12 other states. And we were discussing these issues. And what do we do? What do we bring back to our hospitals? How do we make this thing viable again? And one of the gentlemen there from Michigan made a comment that not too terribly long ago, it's been a couple of years, definitely pre-pandemic, but they had taken a group of CEOs to London, and they wanted to look at how the socialized medicine system was structured and how it was put together. This group of 5 or 6 CEOs went through the hospital, one of the large hospitals there in London, and was just very impressed at what they saw and the services they offered and the quality they did. And they went through the whole tour, and they came back and they started debriefing at the hotel and said, yeah, this is really great. He said, but let me tell you now, if you pick this hospital up and you set it in the middle of Detroit, not less than 15 agencies would have that facility closed before the end of the week.
That's true.
So
it's true.
We have layered so much cost, and one of the things that we look at, Paul, is that, and we struggle with this constantly. But when you have the staff in a hospital to the point that more than 50% of those staff are non-clinical staff, they're not taking care of patients. In other words, they're doing other issues, support things that have to be done, and much of it in regard to regulations. So we have increased the cost so much that it's making it a bigger challenge each and every day to run a hospital.
I was going to say something, and
that blew you away.
I'm frustrated.
Oh, me too.
I know you've got to be frustrated because it doesn't have to be this way.
It does not.
If we're just talking, just you and I, and with this family out there, you got too many damn people making too much damn money off of sick people. And that's it.
Yeah.
I mean, socialized medicine would never work here because too many people would lose out, just as you said.
Yeah.
You'd have to throw out all the environmental groups, all of the woke personality, all the Republican and Democrat bickering. You'd have to throw out all the pharmaceutical control as far as the control the pharmaceutical people have and everybody else. It's too many people with their greedy damn hands in here. And by the time you get to it, a doctor is as frustrated as you are.
Oh, absolutely.
And we know I am. We get look in this battle of cancer that I'm going through. I see it firsthand.
Sure.
There's so many things that don't have to be there. So many checks and balances that have to be done every single time. It's frustrating to these. I feel for them. I really feel for them.
Well, Paul, the sad part is the most frustrated one is the patient. And that's what you're seeing.
That's it.
And that's the reason, the whole reason that we should be doing what we're doing is what is in the best interest of the patient. And it looks like that comes second these days. And it's wrong.
It's like the Medicaid thing here on the expansion. We can never get a clear answer to this. You go to the same sources on both sides of the aisle. The Republicans have different views. The Democrats are lock, stock, and barrel on most of them on expansion. Then when you try to figure out what the financially solvent way to do it is, it's very, very complicated. Short term, long term, because we get a lot of different answers on it. Yeah. Let me go back and ask you this: how many hospitals do you feel like, with the hospital association, are actually in jeopardy of closing in the state?
Oh, we've got probably in the neighborhood of I'll say 5 to 6 that could be in serious concern of closure by the end of the summer.
Where's that? Where are they?
I until they become public, Paul, I just can't. And
all right.
I mean, Greenwood.
They're all small hospitals in small communities.
They're not all small hospitals.
Is that right?
Some of them would be larger hospitals. Now, Greenwood, and I can say Greenwood because it's in the public. You know
yes.
that. You know
what's the status of Greenwood?
Well, they've made a lot of changes. They've decreased the personnel. They're looking at other options and other models that they could potentially move toward. I know they've got folks in Washington trying to help them to bring across maybe some waivers that they would not currently qualify for. And if that's the case, the biggest thing there is making sure that there is access to care. And it's sad because I was in Greenwood for almost 5 years as the chief operating officer up there, and it was a full-service hospital, wonderful medical staff. The staff there was supportive of the hospital. They wanted to see it grow, and then just over time, so much has changed. It's changed in the Delta. It's changed in healthcare. It's changed in the recruiting ability of our small rural hospitals to bring specialists in, and you've just seen that wither away. And it's a sad situation, but
would it have been different, Tim, if they changed with the times, though, as far as downgraded or changed the mission of the hospital?
Well, and they've tried. They tried to do some of that. It's just a difficult model. When you've got a hospital that was originally designed to be 230 beds, that hospital is still there. You've still got all the expense and the maintenance and keeping up with that thing. You've got to heat and cool it. There's no way to cut things off and make it cheaper. So now certainly labor cost and things like that, and that's what they've done. They've trimmed it back. Of course, they're no longer delivering babies in that facility, and that's a worrisome thought.
That's not that's cost prohibitive.
Well,
they have to close that down.
As I understand, the biggest part there was staffing, to be able to staff it appropriately. And that's when they just had to scale it back. Well,
but then that brings up a very good question that would be brought if we were sitting around a table with the legislators. If you increased that capacity with Medicaid, you still have a staffing problem. You got to solve that. It's like the prison, certainly up in the Delta area.
Yeah, no doubt. It is a revenue problem. And we've talked about this all along because costs have gone up so rapidly and so high that revenue did not keep up with it. So we have to solve that revenue problem so that we can stabilize things in order to make changes.
What is the Mississippi Hospital Association's part in this? You're not a regulatory agency, so what do you do? How do you get involved in this?
Paul, we try to advocate. We try to look for different opportunities for hospitals. We have a lot of conversations with the American Hospital Association and with folks in D.C., with CMS, with Medicaid. We try to find solutions. We're a convener, and we try to find solutions.
You have some websites that you go to that's specific to your industry. Think about this question when we come back.
Yeah.
How much waste is there out there? Just absolutely waste and also scam artists and fraud, et cetera, in the health insurance business in this country. When we come back with Tim Moore. Tim is President and CEO, Mississippi Hospital Association, Tim Moore. Tim, when we last left you, I was talking about, you look at the waste and fraud in the entire industry, and it's so massive that some people said you could buy a Cadillac policy under the Obama administration, something called a Cadillac policy for just about everybody whose household income was under $50,000. I don't know if that's true or not, but it is in the billions, is it not?
Yeah, and that's such a broad topic, because if you start looking at fraud and waste, then you have to get down pretty specific. If you look at it on a patient basis, that's pretty limited. You don't see a lot of that. On the provider side, certainly there are opportunities there, but if you start looking at the grand scheme of the whole thing, there's not a lot there, at least that what we see in Mississippi. It is very small. Now, are there bad actors? Absolutely. And should they be pursued and should they be prosecuted? Absolutely they should, because that makes it bad for everybody. But if you start getting into the payer side of it, then you start seeing a lot of other issues that get very gray and very questionable in how payments are made, or the timeliness of payments, or the denials and the pre-certs and all those things that make those hoops even harder for patients and providers to get services rendered and get paid for those appropriately. So, there's a tremendous amount of waste, and I kind of go back to what we were talking about earlier on the staff, that we've moved away from facilities, hospitals that are all clinical in nature, to having all this support staff to try to cover all the additional requirements that have to be done. That, do you consider that waste?
Well, and also the waste that's created by regulations that needs not be there. And I think that itself adds up to, as you said, maybe something that's intangible. You can't put a figure on it, but it adds up in the billions of dollars that it doesn't have to be there. It's not necessary. It's duplicative. Yeah. It's redundant in so many different ways, and there's also a cost in labor time that could be spent with the patient instead of on the computer.
I don't want this to come across wrong, but just I think an important part, the electronic health records. There are some wonderful things that come from electronic health records, but look at the increase in cost that has been put in the healthcare systems, and then just individual hospitals that can't afford to even put the kind of system in that they would like to have, or one that can compete with a larger system, strictly because of the cost involved in it. That's a major issue. Now, does it bring benefit to the patient? Well, some, sure it does. I mean, you have access to a lot of data, and you can do a lot of analytics, and you start doing predictive modeling to understand when people are going to get sick. But there is a cost associated with technology, and at some point, do we decide, okay, we can't go any further because it costs too much?
It's a little bit like, and I've often said this, that the pharmaceutical people spend literally billions of dollars every year on advertising, that many of us don't go to our doctor and said, look, I think I want you to give me this because I saw it on TV. As a matter of fact, I saw 16 ads of it. And it's a waste. All it is it's putting money into it that they could put into research. But one of the biggest lobbyists in this country is the broadcasters, and that is billions and billions of dollars that go into the same people that are controlling the media. So it's going to be very difficult to stop that. But we grew up in an area that didn't have prescription drugs as advertising. Over the counter, yes, but not prescription.
Well, and I think that was a huge mistake, and some of my pharmaceutical friends may disagree with me, but I think direct marketing pharmaceuticals to patients was one of the biggest mistakes we've ever made in healthcare.
Yeah, I agree with you 100%. I really do. It's not needed, and they could take that money. They spend more, and I heard this, and I can't validate it now because this was a figure I got a couple of years ago, but they spend actually more on advertising than they do on research.
Yes, I'm sure, and it works. It works.
Yes, it works. It's a great lobbying tool, and they know exactly what they're doing. In the same manner, using the technology to keep the patient informed, and I know that from the experience I'm going through, we'll get information and a diagnostic readout on a PET scan or whatever, and I read that thing, and it scares the hell out of me when I read it because I don't know what I'm reading. It's a lot like when you start talking about the when you start talking about some of the side effects you hear on some of these ads. But let me ask you this, on the involvement of the hospital association between the dispute Blue Cross and UMMC, what part do you guys play on this?
Paul, we don't. We try to stay out of that one. That's certainly between two parties, and we when you start interfering with two parties that having a contract dispute, you wind up getting pulled into it. So we have not. We have stayed completely neutral. We have other issues that we work with on Blue Cross, and we certainly, as a member, work with UMC on other issues. But that particular incident, we do not participate.
Some of the meetings you've had this summer with any of the legislators at all?
We have. We've had quite a few. As a matter of fact, we've got a group going out now that is meeting with nurse managers, and I know they had two last week, one in the Delta and one up in North Mississippi, and had legislators that were having the opportunity to hear directly from the caregiver of the challenges that they're seeing in hospitals and how difficult it is now to manage, and that we desperately need some help. And look, I do want to shout out.
Sure.
Shout out for Medicaid, because they are doing some things. We had some conversations with the Lieutenant Governor and Speaker, and they really went to work with Medicaid, and we're looking at a potential add-on to our supplemental payment program, which is going to be very helpful. It's not going to solve the problem completely, but it is much appreciated, and it is the moving.
Are you telling me that the outgoing Speaker is in accordance with that?
He is, as far as I know, has been supported. He was in that meeting, and this is not. It's not expansion. It's not expansion. It is a support of.
Is that just a different term? Different term? It's
no. It's a.
Are you sensitive to that term, or tell me why it's not the same thing as expansion?
Well, what this is we do it now. We have a what we call a Mississippi Hospital Access Payment, and that's a pass through from the managed care companies that's on a match, but it covers the gap between what Medicaid pays and what Medicare would have paid had they provided the service. Well, some of the states have come back, Louisiana being one of them, made a change in their waiver, and they're using an average commercial rate. That, as you can imagine, increases that number slightly. In Louisiana, it was worth $900 million.
Yeah.
Ours is not, because, of course, we're not as big as Louisiana, nor are our commercial rates as high as Louisiana's. But it is a significant amount of money, and it just increases the money coming into that program.
How many more people are we talking about added on?
Nobody. This helps us pay for the ones that we got.
I got you. Yeah. Real quick, because I'm going to run out of time here, and I got a couple of other questions. The pharmaceutical the managers of these pharmacies, as we set the prices, is anything going to happen there?
Paul, the PBMs? Is that
PBMs, yeah.
I don't know. There's certainly a lot of scrutiny there now, and I think they're going to be watched a lot closer. Certainly, that's an area that seems to have all of a sudden become very abused, and we're very supportive of that being watched closely.
Some change in the pharmaceutical or in your organization as far as True Care?
Well, that's still underway, so I can't comment on that one.
That's not a done deal yet?
It's not done yet. There's a protest underway, and we're waiting to get that finalized.
Centene is their deal done?
No.
So all of that. When is that going to be done? Is that?
We'll have to wait till we hear from the court, but we hope in the very near future. This is one of those rhetorical questions, but the top objective for the 2023 session is? That would be getting additional revenue to our hospitals. And we've got several ways that we can do that. We've had a couple of Senate hearings, both on Medicaid and public health, and we gave some solutions, gave some options. So we'll continue to be promoting those and having discussions about them. And, Paul, the number one thing to do would be expand Medicaid, but that's not what we're trying to. There's other options, okay? We're saying, look, this is so important. We've got to get revenue in. Don't worry about expansion.
You feel like the atmosphere is a little bit better, the environment's a little bit better to do that in 2023?
I think it's better to try to increase the revenue to hospitals. I'm not overly optimistic about Medicaid expansion.
Would you keep us informed, sir?
Yes, sir.
During the legislative session? It's always good seeing you.
Good to see you, sir, and best to you. I hope your process continues to go better and better.
Same here. Tim Moore, President, CEO, Mississippi Hospital Association. Tim, thank you.